normal growth and growth assessment in children, short stature causes and evaluation, and growth hormone treatment. Growth during childhood and adolescence is the most sensitive indicator of well-being. If the child is growing well, then he is well. Normal growth only occurs if the child is healthy, adequately nourished, and emotionally secure. Why short stature? Short stature is a symptom. It's not a disease. It is a symptom. It is a sign of many underlying conditions. When a child is short, this might reflect an underlying chronic disease like celiac disease or chronic kidney disease. It could also reflect an underlying endocrine problem like hypothyroidism or multiple pituitary hormone deficiency, genetic disorders like Turner syndrome, Down syndrome, and it could be simply a reflection of psychosocial deprivation. And I'm going to combine Arabic and English في اللقاء لأن الحقيقة هو المفروض يكون اللغة إنجليزية. Okay. طيب. For the epidemiology of short stature, according to the definition, 97.5% of the population belongs to normal and tall stature. Only 2.5% عندهم short stature. لكن in certain countries, in certain environments, there are more prevalence. A rate is more. Like in Pakistan, it was reported that the rate of short stature is 16.5%. In India, it was 36.8% in boys and 36.9% in girls. In Saudi Arabia, as it is shown here, it is 11.3% in boys and almost 10.5% in girls. So this is really a considerable rate of prevalence of short stature. That's why we have to understand the causes and how to treat children who present to short stature to the clinic. And to be able to treat short stature in children, we have to understand the major factors that affect growth during childhood, and how do we assess the growth in children, and how do we interpret these measurements. So I'm going to take you through all these in the coming slides. The major factors involved in growth are genes, hormones, nutrition, and environment. Actually, the interaction between these factors results in the adult stature. So we're going to take them one by one. We're going to start with the genes. Growth in many directions is a polygenic process. It involves numerous single genes on many chromosomes. The allelic combination is important. So if one of the alleles is not present, like in heterozygous disorders, the stature will be affected. The gene-gene interaction is very important, and the environment and gene interaction are very important. Height is highly heritable. Heredity accounts for around 90% of total adult stature. The mean adult height difference for the monozygotic twins is less than 2 centimeters, and the mean adult height difference for dizygotic twins of the same sex is around 5 centimeters. So they've drawn this conclusion from the twin studies, and this is very important because during assessment of child with short stature, it's very important to consider the family. The child has to grow to his family potentials. If the parents are short, it's very difficult to make the child tall. So, and this is one of the very common actually argument in the clinic, because most of the parents, they feel that we are short, we don't want our boy or our girl to become short as us. And this is important because when we diagnose familial short stature, it's very important actually to exclude the pathologies in the parents themselves. So we have to take both the parents and the child into account. The second factor is the environment. Actually, interaction between genetic adaptation and climatic conditions is very important in determining the short stature. The extremely cold climate favors short, round individuals, and individuals from hot climates are generally tall and thin. And this will take us to the fact that children usually grow better during spring and summer. So during these seasons, they grow better than winter. That's why we think the environment has a major role. This will affect our measurements. If we are following a child with short stature or with growth failure, we have to consider the seasonal variation, because it might seem that the child is not growing, but it is only the season. He's not growing during winter as fast as he is growing during spring or summer. So we have to take into account the importance or the effect of environment on growth. Genes involved in growth actually are many, and we can take several hours talking about them and describing them, but we are going just to briefly mention the important genes. Genes that are important for the growth of the pituitary gland in fetal life are important in regulating the stature in adulthood, and also genes that are involved in the hypothalamus pituitary control, genes that are affecting hormones related to growth, like growth hormone, insulin-like growth factor 1, thyroxine or thyroid hormone, adrenal hormones, also very important. Insulin are also very important for growth. The genetics of the growth plate, or the genes that control growth plate, are very important. As in this slide, we have the long bone here, the epiphysis, the growth plate, and the metaphysis, and this is the histological section of the epiphysis. The epiphyseal growth plate is very important, actually. Healthy epiphyseal growth plate is very important for growth, and all the genes that regulate this epiphyseal growth plate are involved in the control of growth. The third major factor in controlling growth is nutrition, and actually suboptimal nutrition is one of the commonest causes of growth failure globally. It's not necessary that the lack of food, yes, is prevalent in poor countries, but also self-restriction, like in those playing gymnasium, those who have anorexia nervosa, children who are picky eater. It's very important to check the nutritional history of the child, and it's not only the macronutrient, the proteins, the carbohydrates are important, but also the minerals and the micronutrients are very important in controlling growth. We have short stature because of iron deficiency, short stature because of zinc deficiency. Hormones are the third major or the fourth major factor in controlling growth, and there are many hormones that are involved in growth. Actually, the growth hormone, the name, major hormone secreted by the pituitary gland that regulates the insulin-like growth factor 1, which is a peptide produced by the liver and other tissues in response to growth hormone, and it actually mediates part of the growth hormone action in linear growth. The insulin, which is required for substrate utilization, the thyroid hormones, which are very critical for metabolism and growth, sex steroid hormones, which are responsible for speeding linear growth during puberty, which are also responsible for fusion of growth plate at the end of the growth, especially the estrogens. Cortisol also is a very important hormone that regulates growth. Excess of cortisol impairs growth, and deficiency also causes growth failure. Coming to the next part of our talk about normal growth. Actually, the normal growth was divided into phases: the fetal, the infancy, childhood, juvenility, and puberty. Because the factors that regulate growth in each phase is different, and the tempo of the growth in each phase is quite different from the other. Technically, fetal life is not a part of childhood, but it's worth mentioning because growth during fetal life, it has a very large impact on the adult stature. Growth during fetal life is mainly affected by the maternal health, which we call the maternal environment, if the mother is healthy or not, if the mother is taking drugs, if the mother is short or small, the child will be short and small as well. If the mother is having conditions like diabetes, the child or the baby will be large and macrosomic. And it is regulated by insulin and insulin growth factor 1 and 2. We can see that there is no rule for growth hormone during this period, but this period actually is very important. The most rapid growth is before birth. The child starts from a small cell to 50 centimeter curvature. This comes to 100 centimeter per year. So anything that affects the child growth during this period, whether affects the weight only or affect the length only, or both weight and the length, will affect the individual growth during adulthood. Small for gestational age, children born small for gestational age, 20% of them were developed to be short as adult. عشان كده it is one of the indication for growth hormone therapy if they don't catch up growth up to 4 years of age. Small for gestational age. That's why we have to obtain the birth data, the birth weight, the birth length, when we assess a child with short stature. The infancy period, usually we define the infancy by weaning, and it's mainly regulated by nutrition, insulin, IGF-1, and the thyroid hormone. So the thyroid hormone takes role into regulation of growth of infancy, and this will continue throughout the other phases, but the major factors here are nutrition, insulin, and IGF-1, and the thyroid hormones. When we come to the childhood, which starts from the second year of life, the growth hormone IGF-1 takes part into growth control, and actually its major part. The thyroid hormones are very necessary. Again, the nutrition is important. So the factors will be carried on all through, but in every phase, we have the key factor that controls growth. So growth hormone IGF-1 is the major controller of the childhood growth. The juvenility period, which is the period between the childhood and puberty, is mainly regulated by the adrenal androgens. And then when the child enters puberty, the sex steroids are responsible for what we call the growth spurt. Here, the phase where the child actually goes from an immature child to a mature fertile adult. So growth depends on nutrition, genes, environment, hormones, and love. Actually, they need care. They need care. Psychosocial deprivation is one of the very common causes of short stature in children, and we have to assess the child very carefully for any abuse during short stature assessment. By this, we have come to the end of the normal growth phases and the factors that affect the growth. Now we're going to talk about the assessment of growth. Accurate measurement is the key. It's very important, and sometimes some referral because of short stature might be just because the measurement is not actually correct. So we use the infantometer for the measurements of infant. We measure the length, those who cannot stand. We use the stadiometer for the measurement of children who can stand up. So we have linear growth for infant, and we have height or stature for those who can stand above 2 years. In every clinic, we have to measure the parents. It's very important because the child will grow up to his potential. If his parents are tall, he's going to be tall. If his parents are short, he's going to be short. Have already obtained accurate measurement, we have to plot them on the growth chart. And the growth charts are actually centile. We have centile chart and we have the standard deviation or z-score chart. The common that we use is the centile chart. So any child who's growing below the third centile, which equals to -2 standard deviation, is considered short. The x-axis of the chart is the age, and the y-axis of the chart is the measurement, اللي هي height in centimeter. It's very important the date of birth should be obtained, and the chronological age should be calculated correctly. A child who's 5 years is not doesn't have equal stature for the child who is 5.6 years. So we have to obtain the chronological age correctly. The normal range for growth is between the 3rd centile and the 97th percentile, which is plus and minus 2 standard deviation. The target height is the mid-parental height. We have to obtain the parent's height, and the child should follow his family channel. We can see in this growth charts, this is a child with short parents. His target height is just below the 3rd centile, so he's really following his parent. And this is a child with normal parents, and again his channel is following his parents. It's very important. So when we measure the child, we have to measure his parents. We have to predict his height according to his family. Assessing puberty is very important into assessing child's height. Usually the difference between adult male and adult females is around 12 to 13 centimeters. This comes from 2 factors. Males enter puberty later than females. Puberty in females start earlier, and so they spend more in childhood growth and they gain more. And the other factor sorry, I have a problem. I had a problem. Actually, we said that adult males and adult females difference in growth is around 12 to 13 centimeters because males enter puberty later than females. We can see that the growth spurt in females is earlier. Males spend around 2 years into childhood growth, and this gives them around 6 to 8 centimeters more. Plus the pubertal growth spurt is actually more in males. That's what gives them the difference of around 12 to 13 centimeter. Some children, they have average tempo of puberty. They enter puberty in the normal age, اللي هو between 18 to 13 years, between 8 to 13 years in females and between 9 to 14 years in males. Some of them, they have late puberty, but they attain normal height. So it's very important to assess the pubertal stage in children, and we have to ask about the family history regarding puberty in parents. The growth hormone secretion increased markedly during puberty because of the effect of sex steroids, and this also affects the tempo of growth. Measuring the height, we have to consider the height velocity, and this is the most sensitive factor in detecting growth abnormalities early. because if we measure the growth velocity, we can detect growth failure before it becomes a short stature. So a child more than 2 years has to grow more than 5 centimeters per year. If a child is growing less than 4 centimeters per year, we have to monitor him carefully. During puberty, the peak height velocity is 5 to 11 centimeters per year in boys and 6 to 10 centimeters per year in girls. At least 6 months has to be between two measurements to assess the growth velocity. This is the rule of 5 for normal growth rate in children. A child is born 50 centimeters in length, and then he gains 25 centimeters in the first year, and then he gains 10 centimeters afterwards. At 4 years, most of the children are around 1 meter, and then they gain 5 centimeters per year until they enter puberty, when the tempo changes to 6 to 10 in girls and 8 to 11 in boys. This is the growth velocity chart, and we can see that there are early maturer, those who enter puberty early, and we have those with normal tempo, and we have also the late maturer, those who enter puberty later. So the growth should be assessed according to the growth velocity, the relation between height and weight, the relation to parental height, and the relation to the population. And as we mentioned, if we assess the growth velocity, we could detect the growth failure. Short stature is any child who is less than 3rd percentile or more than 2 standard deviation below the mean for age, sex, and population. But growth failure is not necessarily a short stature. Any child who's crossing centile, whose height velocity is low, will be diagnosed as growth failure. So if we have a growth problem and we have plotted the measurement and the child is really short and he is below the 3rd centile, we have to assess his weight as well. And we have to determine whether it is height problem or weight problem or both. In this chart, we can see that this child has both weight and height problem. His weight started to falter before, and then the height follows. And we can see in this that this child has no weight problem, but his height has problem. Reviewing the history of the child is very important to ask about the pregnancy, the delivery, the neonatal period, and we have to obtain the birth weight and length, the feeding history, and the current eating habits, measurements during infancy and childhood. We have to review the system because the chronic diseases are actually affecting growth. They affect the weight first, and then they affect the height. We have to take the past history of illnesses, accidents, or surgeries, and history of emotional stress. Psychological history is very important in assessing a child with short stature because this could be the only cause. Family history, the parental age at conception, short stature in sibling and parents, history of abnormal growth patterns in family, mid-parental height, and it should be sex adjusted. If he is a boy or a girl, we have to adjust the mid-parental height for the sex of the child. We have to check what we call the proportion. The proportion of the stature means the trunk to the limbs. Does the child have normal trunk and short limbs, or does the trunk itself is affected? Because this will help us to diagnose many of skeletal problems. Children with scoliosis, اللي هو lateral curvature of the spine, might be short. Children with certain skeletal abnormalities like short 5th and 4th metacarpal might be diagnosed with certain syndromes or skeletal problems. So all these are clues from a physical examination. Looking at the child, we have to look for dysmorphic feature, genetic chromosomal disorder like Down syndrome, Turner syndrome, bone problems, as we said, scoliosis, kyphosis, short limbs, short trunk, chronic systemic disease, chronic renal failure, celiac disease, endocrine disorders, and we have to assess the puberty. The first sign of puberty in females is breast enlargement. The first sign of puberty in males is testicular enlargement. We have to look if the child has infantile appearance, micropenis in boys, if he has goiter for hypothyroidism, if he has short metacarpals, as said, and we have to detect whether it is only a height problem or the weight is also affected. Because in chronic diseases and nutritional problems, the weight is affected initially, and then the height follows. But in endocrine problems, usually they have the weight on the higher side, or maybe they are obese, but they are short, like in Cushing syndrome, in growth hormone deficiency, in hypothyroidism. Most of these conditions associated with endocrine disturbances, the weight is actually normal or high. But if we're talking about systemic disorders, chronic diseases, then the nutritional disorders, then the weight is affected first and the height follows. This is a case of disproportionate short stature, like in achondroplasia. We can see that this child has short limbs. This is a child with typical dysmorphic feature of Turner syndrome. You can look at the neck. She has webbed neck, wide webbed neck. And we can see that they could have other problems like shield chest or wide space nipple. They have increased carrying angles and so on. So looking for dysmorphic feature, looking for skeletal problems are very important. Always we have to assess the puberty. Doing that, we divide the causes of short stature into normal variants. Not all the short statures are pathological. We have normal variants of growth, which are familial short stature and constitutional delay of growth and puberty. And we have the pathological short stature. The pathological short stature, we divide it into proportionate short stature and disproportionate. By disproportion, we mean that the trunk and the limbs are disproportionate. Either he has short limb or the trunk is affected, like in rickets and skeletal dysplasia. Proportionate short stature, it could start from the prenatal period, like small for gestational age, as we mentioned, placental disorders, infection in the mother, teratogenes, dysmorphic syndromes, or chromosomal disorders. Postnatal, either nutritional or chronic disease or endocrine problems. Looking into the variance of normal variance of short stature, by normal we mean that there is no pathology. We have the familial short stature. Usually both sexes are affected and the child is normal at birth. There is positive family history of adult short stature. The adults in the family are short. The parents are short as well. The height velocity is below normal, but it is more than 4 centimeters per year. So it's not growth failure actually. The puberty is at normal age. Their bone age is equal to their chronological age. We assess the bone age by doing an X-ray for the left hand and wrist. We're going to show this later. And the final adult height is short. The constitutional delay of growth and puberty is more common in boys, and they have normal birth weight and length. The family has positive history of delayed puberty. The parents' stature is average. The height velocity is normal, but they have delayed puberty. Their chronological age is more than their bone age. And if the child is 14 years, his bone age is usually around 12 years or 11 years. So he has a room to increase his height. And usually they have normal adult height. This we call them late bloomer. They enter the puberty late and they become tall. Another category that we have also non-pathological, the idiopathic short stature. The height is more than 2 standard deviation below the mean. There is no evidence of systemic, endocrine, nutritional, or chromosomal abnormalities. Normal growth hormone level after stimulation. The child is actually 2 standard deviation below his mean mid-parental height score, and his bone age is actually and height age are actually equal, and this is one of the indication for growth hormone therapy if the child fails to catch up. In familial short stature, we don't offer growth hormone. In constitutional delay of growth and puberty, we don't offer growth hormone, but in idiopathic short stature, we can offer them growth hormone and they respond. After assessment, there are certain laboratory investigation. We have first line, and we have second line, and we have third line investigations. Actually, we start with the chemistry, blood count, thyroid function test, antibodies for celiac disease, IGF-1, IGF binding protein 3, karyotype for girls because of Turner syndrome. All girls with short stature, we have to do karyotyping because of Turner syndrome. For boys, if they have dysmorphic feature, we have to do karyotyping. Then we have to assess the skeletal maturation, the bone age. The most important thing in assessing the bone age is left hand and wrist X-ray, and we have to look at the epiphysis for the ossification center. We have to look for the ossification center, because if the epiphyses are closed, there is no chance that this child is going to grow, and usually the epiphyseal plate is closed around 14 years. The third line, if indicated, we can go for growth hormone testing, and usually we do stimulation test using insulin, glucagon, or clonidine, and we, if indicated, we could do an MRI scan for the hypothalamus pituitary gland. So, talking about the growth hormone is a polypeptide hormone, and it's usually synthesized in the and secreted by the anterior pituitary. There are many factors that affect growth hormone secretion, like stress, fasting, the amino acid fatty acids, glucose, sleep, temperature, exercise, and sex hormone. All these stimulate the growth hormone secretion. The somatostatin has an inhibition rule onto the growth hormone. Growth hormone stimulates the secretion of the IGF-1 from the liver and other tissues. The growth hormone is usually secreted in pulses, 10 to 20 times per 24 hours. Most of the growth hormone is released during sleep, 1.5 hours after sleep, and the highest peak actually is obtained around 10 to 11 p.m. And you can see that most of our children these days are not sleeping during night, or they're sleeping very late. And this, I think, is one of important issues we have to address talking about the growth hormone. And the peak, it is if we want to have a good peak of growth hormone, the child has to go to sleep around 8:30 to 9 p.m. The overall 24-hour secretion varies with age and sex. The pulse amplitude correlates with height velocity. So if the pulse amplitude is high, then the height velocity is going to be high. Pulse amplitude increase markedly during puberty. You can see that in some time of the day, the growth hormone secretion might be just 0. So there is no rule for random sample for growth hormone. And you cannot send the patient to the laboratory just to take a random sample. Unless we stimulate the growth hormone with another pharmacological agent, it's not, it will not be easy to assess if the child is having growth hormone deficiency or not. This is the growth hormone releasing hormone, growth hormone IGF-1 axis. The hypothalamus secretes the growth hormone releasing hormone, which stimulates the anterior pituitary. The anterior pituitary stimulates the production of the IGF-1 and IGF-1 binding protein 3 and acid labile unit from the liver. Also, the growth hormone has its own local effect on the target tissue, especially the muscles and bone. The IGF-1, IGF binding protein 3, and the acid labile unit complex goes through the circulation to the target tissues, the bones and the muscles. The effect of growth hormone actually is not only on linear growth. It is needed for the brain growth, the cognitive function. It is needed for healthy fat distribution, and it is needed for muscular growth. This is very interesting. This is a boy with classical growth hormone deficiency. You can see at age 3.3 years when the growth hormone started, he has very immature face. He has what we call rippling of the abdominal fat. The fats are mainly central, and he is really short. You can see after 3 months, the more mature look on his face, because the growth hormone is really very important for cognitive function of the brain. And you can see the distribution of the fat is even. The rippling of the abdominal fat is actually not seen anymore. And after 1 year, you can see the marked increase in his height. So brain, fats, muscles, and linear growth, all these are the effects. It has metabolic effect, and it has effect on the linear growth. In each individual, there should be a balance between growth hormone secretion and growth hormone sensitivity. And we have quite a number of cases of short stature because of growth hormone insensitivity. Either the problem is at the level of the growth hormone receptor, or at the level of the IGF-1, or at the level of the complex of IGF-1, IGF binding protein 3, acid labile unit, or post-receptor problem. The classical signs of congenital growth hormone deficiency during infancy, they present with hypoglycemia, micropenis in boys, and prolonged neonatal jaundice. So taking history of the birth and postnatal period is very important. During childhood, they present with growth acceleration after the 2nd year. They have cherubic facial appearance. They have delayed dentition. They retain their baby fat, the central distribution of the fat. They have acromegaly, small hands and feet. They have delayed gross motor development. During teenage, they have delayed puberty, young appearance for their age, and they have central adiposity. So the presentation varies according to the phase of the growth. The growth hormone disorders and short stature, either it's growth hormone deficiency, which could be isolated, or combined pituitary hormone deficiencies. Growth hormone deficiency could be congenital or acquired. Growth hormone insensitivity is another disorder that can cause short stature. Not all short statures are responsive to growth hormone. This is a fact. The indication for growth hormone treatment are either growth hormone deficiency states, congenital or acquired, isolated or combined, or non-growth hormone deficiency states like Turner syndrome, Prader-Willi syndrome, idiopathic short stature, small for gestational age, chronic kidney disease, Noonan syndrome, and short stature homobox gene. All these non-growth hormone deficiency indications, they don't have growth hormone deficiency, but it was proved by research that they have some degree of growth hormone insensitivity, and they respond to higher doses of growth hormone. Mind that if we have multiple pituitary hormone deficiency, if the cortisol, thyroxine, and growth hormone are deficient, when we start to replace, we have to start with the cortisol, because it's the cortisol is necessary for stress and it's necessary for metabolism. Then we should add thyroxine, and after that we should supply the child with growth hormone. We have many preparations in the market for growth hormone, and there are many companies, the Novo Nordisk and other companies, they produce growth hormone. There are many devices, but it's mainly administered via subcutaneous injection, and up to now, the growth hormone that is available in the market is the daily injection. So when we decide to give the child growth hormone, we have to take in consideration that this child is going to take daily injections every day. It has to be administered at night, 30 minutes before sleep. And compliance is very important for growth. This is the Novo Nordisk somatotropies. For the adverse effects and safety issues, side effects of growth hormone are increased intracranial hypertension, اللي هي pseudotumor cerebri, edema, slipped capital femoral epiphysis. The child might present with limping and lower limb pain, worsening of the scoliosis. So we have to assess if the child has scoliosis from the beginning, gynecomastia, hyperglycemia, and malignancy. Children receiving growth hormone who have had a malignancy account for approximately 20% of patients treated with growth hormone. Like, the fact is, growth hormone does not increase tumor recurrence in persons successfully treated for their primary lesion. The increased risk of leukemia is limited to children with underlying conditions that already predispose them to develop malignancy, those who have the genes. Waiting 1 year after completion of the chemotherapy with no evidence for further tumor growth before initiating growth hormone is important. So any child who has completed his tumor therapy, we have to wait for 1 year before we initiate growth hormone. Monitoring and dose adjustment, the routine follow-up is by a pediatric endocrinologist or a pediatrician in primary care. Height velocity should be evaluated every 3 to 6 months. We have to monitor the serum IGF-1 and IGF binding protein 3 once per year. We have to monitor the free T4 and TSH because hypothyroidism might appear during growth hormone therapy and is one of the causes of failure of therapy. If the child has hypothyroidism, it has to be treated first. His thyroid function has to come back to the normal before we restart growth hormone. When impaired carbohydrate tolerance is suspected, measurement of fasting blood sugar and hemoglobin A1C is indicated. So growth hormone doesn't cause diabetes, but in those who are prone to develop diabetes, we have to carefully monitor the fasting blood sugar and hemoglobin A1C. It's very important to involve adult endocrinologists because we have the transitional period from pediatric to adult care. The updates, the long-acting growth hormone preparations are up to the market and they are FDA approved, and it's weekly injection. And I think this will reduce the burden of everyday injection, and it's really a great success. The oral secretagogue of growth hormone therapy, the LUM-201, that increase the growth hormone pulsatile secretion by stimulating the growth hormone receptor, the ghrelin receptor. This is in phase 2 trial, but it has very good results actually. And if we come to an oral preparation that can improve growth, I think this is a huge success. Okay, we need 4 hugs a day for survival, 8 for maintenance, and 12 for growth. And this actually emphasized the importance of well psychological health in children growth. By this, we come to the end of our talk. Thank you very much, and your questions are very welcome.
يعطيك العافية دكتورة، شكرا لك، أثريت اللقاء بمعلوماتك القيمة.
بارك الله.
في يعني هل ممكن نختصر في 5 دقائق بالعربي؟ يعني ممكن كتعريف وكطريقة علاج، لأنه في
جدا
طلب الحضور. الله يعطيك العافية، شكرا.
مرحب جدا.
الله يسعدك.
مرحبا، الله يكرمكم. مرحبا. الحقيقة هو الكلام عن قصر القامة وهرمون النمو في الأطفال كلام طويل، لكن كاختصارا الطفل عادة عنده تقريبا 4 مراحل في نمو. النمو في الأطفال أهم شيء نحن بنركز عليه إنه في عوامل كثيرة بتأثر على النمو في الأطفال، أهمها العوامل الجينية. لذلك يعني إذا كانت الأسرة فيها مشكلة بتاعت قصر قامة، ده بيخلينا نحن لازم نركز. عشان كده واحدة من الحاجات المهمة نحن we have to measure، لازم نقيس الأب والأم، ولازم ناخد التاريخ المرضي للأسرة إذا كان عندهم مشكلة في قصر قامة. الشيء الثاني التغذية يا جماعة، التغذية مهمة جدا بالنسبة لنمو الأطفال، وهي عامل مهمل الآن، لأنه معظم الأطفال الآن بيقولوا عليهم بيكي إيتر، يعني الطفل ما بياكل كل المواد الغذائية المهمة وبيختار أشياء معينة in favor of others، فبالتالي ده بيأثر على النمو حقهم. الشيء الثالث البيئة، والبيئة بتدخل فيها أشياء كثيرة، منها المناخ، منها الجغرافيا، ومنها برضو الحتة بتاعت الكير اللوف، يعني المحبة والاهتمام بالطفل. لأنه واحدة من الأشياء اللي هي ممكن تأثر على الطفل، على قامة الطفل وعلى نموه، اللي هي الناحية النفسية. بالإضافة للهرمونات اللي هي الهرمونات، مش فقط هرمون النمو، هرمون الغدة الدرقية، هرمون الغدة فوق الكظرية، الإنسولين، وهرمونات البلوغ. دي من الهرمونات المهمة جدا، كل الهرمونات دي بتأثر. المراحل بتاعت النمو نحن بنقسمها لما قبل الولادة. ما قبل الولادة من ناحية تقنية هي ما بتدخل في نمو الطفل بعد الولادة، لكن كمرحلة هي مهمة جدا. عشان كده الطفل اللي بيولد صغير حجما وزنا طولا، ده كل الأشياء دي ممكن تأثر على طوله. يعني 20% من الأطفال اللي بيتولدوا مش بس خدج، يعني ما بالضرورة أنه يكون خديج، لكن حتى وزنه قليل أو طوله قليل بالنسبة لعمر الحمل، ده معرض انه هو ممكن يكون عنده قصر قامة في المستقبل. ودي واحدة من الحالات اللي احنا بعد 4 سنوات اذا الطفل قصير بنبدأ هرمون النمو من غير اي تفاصيل كثيرة، بس لانه احنا عارفين تماما انه الطفل هذا كان صغير في الولادة. نجي للمرحلة بتاعت ما قبل الفطام، اللي هي المرحلة بتاعت الرضاعة، ودي مهم فيها جدا التغذية. عشان كده الرضاعة مهمة جدا. مهم فيها العوامل بتاعت انه يكون عنده انسولين، لانه ثبت انه الاطفال اللي عندهم مشاكل في افراز الانسولين بيكونوا صغار في المرحله دي. بيدخل معانا هرمون الغده الدرقيه في النمو. لما نجي لمرحله المرحله بتاعت الطفوله، اللي هي مرحله سن من السنتين لمرحله ما قبل البلوغ، دي المرحله اللي هي بالضبط مرحله هرمون النمو، اللي بياخد فيها هرمون النمو كل التنظيم بتاع النمو بتاع الطفل. وهنا مهم جدا، يعني اي طفل تكون عنده مشكله بتاعت قصر قامه ما بعد السنتين، لازم نحط في بالنا انه احتمال كبير يكون عنده مشكله في هرمون النمو. نجي للمرحلة بتاعت البلوغ، وهنا مهمة فيها هرمونات البلوغ. عشان كده أي طفل يجينا ما بعد سن 8 سنوات في البنات، ما بعد سن 9 سنوات في الأولاد، لازم نحدد إذا هو دخل البلوغ ولا ما دخل. البنات بيدخلوا البلوغ بزيادة في حجم الصدر، الأولاد بيدخلوا البلوغ بزيادة في حجم الخصيتين. فدي من الأشياء المهمة اللي احنا نخلي بالنا منها، لأنه الطفل ممكن يتأخر في البلوغ، وبالتالي المرحلة دي يكون قصير، وبعد فترة يدخل البلوغ عادي زيه زي باقي الأطفال، لكن في سن متأخرة، وفي النهاية بينتهي طوله طبيعي. فدي من الأشياء اللي احنا بنركز عليها، والأهل بيقلقوا، لكن بمجرد انه احنا نعرف والله يا جماعه الطفل ده هو عمره مثلا 13 سنه وللان ما دخل في البلوغ، هرموناته طبيعيه، وضعه طبيعي، ما في امراض، احنا نتابعه، ممكن يدخل البلوغ بعد سنه او بعد سنتين، وفي النهايه ينتهي طوله طبيعي. دي بتخلينا نقسم قصر القامة لقصر قامة فسيولوجي وقصر قامة باثولوجي أو مرضي. الفسيولوجي زي ما قلنا يا إما أسرة قصيرة الأب والأم قصيرين، يا إما الطفل مشكلته في إنه هو زي ما بنقول الريتم حقه أو التيمبو حقه بطيء، هو لوحده نموه بطيء، بينمو ببطء ويدخل البلوغ على راحته بعد 14 سنة مثلا، وفي النهاية بينتهي طبيعي. دي بنسميها فسيولوجية، ما عندها مشاكل. عندنا الباثولوجية اللي هي ممكن تكون مشكلة في الهيكل العظمي نفسه، اللي هو في النمو عادة في العظام الطويلة، أو ممكن يكون عندنا مشكلة في الإفراز بتاع الهرمونات اللي هو قلنا قصور في الغدة النخامية، قصور في الغدة الدرقية، قصور في الغدة الكظرية أو زيادة، مشكلة في الإنسولين. دي كلها ممكن تعمل قصر قامة. ممكن يكون عنده واحد من الأمراض المزمنة، يعني فشل كلوي، مشاكل في القلب، ربو مزمن، مثلا مشاكل في الامتصاص زي الناس اللي عندهم حساسية القمح أو الناس اللي عندهم الأمراض بتاعت الجهاز الهضمي. كل دي بتأثر على القامة. أو مشاكل تغذوية، الطفل عنده مشكلة بتاعت سوء تغذية لأي سبب، هو ما بياخد الأكل كفاية أو بيرفض. دي كلها ممكن تسبب مشاكل باثولوجية في قصر القامة. إذا حددنا السبب بعد كده بنحدد العلاج. يعني ما كل قصر قامة بيعالج بهرمون النمو، لكن في حالات محددة اللي احنا حددناها، إما إنه يكون عندهم نقص في إفراز هرمون النمو، أو إنه في حالات معينة بندي فيها اللي هي بعض الحالات الكروموزومات، مشاكل الكروموزومات، اللي هم الأطفال اللي عندهم داون أو الأطفال اللي عندهم تيرنر، أو أحيانا بعض مشاكل الجينات، أو أطفال اللي عندهم مثلا فشل كلوي مزمن، لأنه الفشل الكلوي مزمن بيكون عندهم مقاومة لهرمون النمو، بيستجيبوا لما نديهم العلاج. فيبقى الحالات فقط اللي احنا عرضناها دي هي اللي احنا عارفين تماما إنه الأطفال بيستفيدوا من هرمون النمو فيها. هرمون النمو نفسه هو عبارة عن بروتين، وبيعطى كعلاج للحالات دي عن طريق الإبر تحت الجلد، موجود في شكل أقلام، وفي كمية من الشركات بتنتجه. لكن بالنسبة لهرمون النمو عشان يدي تأثيره لابد إنه يعطى قبل النوم. والحتة دي أنا بركز عليها جدا، لأنه الإفراز الطبيعي لهرمون النمو بيكون بعد النوم بساعة ونص، والنوم لازم يكون بدري عشان ناخد إفراز جيد. المفروض الطفل يمشي السرير 8 ونص ل 9، ولا ده ما بيحصل بقى الأيام دي. وعشان العلاج يستفيد منه المفروض ياخد العلاج قبل النوم بنص ساعة. فبالتالي احنا بنعتبر انه العلاج مرهق شوية وممكن يكون متعب. فواحدة من الأشياء الجديدة والجميلة إنه الآن طلع في السوق يعني نوع من الهرمون النمو بيعطى مرة واحدة في الأسبوع، وفي دراسات وأبحاث على محفز لإفراز هرمون النمو بيعطى عن طريق الفم، لكن الآن في مرحلة البحث. بالنسبة للأعراض الجانبية لهرمون النمو، عادة يعني هرمون النمو يعتبر دواء آمن ما فيه مشاكل، لكن ممكن يسبب ارتفاع حميد في ضغط الرأس، وده بيجي صداع للطفل وممكن شوية استفراغ. وفي حالة زي دي بنوقف العلاج وبنرجعه تدريجيا. ممكن يعمل مشكلة في المفصل الورك، والطفل هنا بيجي بآلام في الرجل، وبرضه بنقلل الجرعة بسيط وبعدين بنرجع العلاج. في بعض الأطفال اللي هم أساساً معرضين للإصابة بالسكري، مش الطفل بيكون عنده جينات السكري وهو معرض للإصابة بالسكري. في حالة زي دي لازم نخلي بالنا في متابعة الطفل إنه إحنا نقيس السكر عشان نكون إحنا متأكدين إنه أمور السكر عنده كويسة. بالنسبة للأطفال اللي بيكون عندهم مشاكل بتاعت كانسر، يعني كان عندهم ليوكيميا أو كان عندهم أي نوع من أنواع الكانسر، لم يثبت أبدا إنه هرمون النمو بيسبب زيادة في نسبة الأورام أو بيسبب رجوع الأورام عند الأطفال. الفئة اللي كانت الناس بتتحدث عنها دول الناس الأطفال الأساسا هم عندهم الجينات اللي بتسبب ظهور الأورام. لكن عادي إذا أي طفل كان بياخد علاج لليوكيميا أو أي ورم، عادة بننتظر سنة وبنرجع نبدأ العلاج بهرمون النمو بعد مرور سنة، باعتبار إنه الطفل أموره كلها سليمة. تقريبا ده ملخص الحديث. أتمنى إنه يكون واضح ومفيد.
واضح جدا دكتورة، يعطيك العافية. شكرا لك على ترجمة العرض بالعربي، شكرا لك، جزاك الله خير. دكتورة، في سؤال، مثل ما أنت ذكرتي إنه النوم هل هو فعلا يؤثر على هرمون النمو؟
يؤثر
جودة النوم
يعني دي أيوة، ده دورة النوم مهمة مهمة جدا. لأنه نحن زي كان عرضنا واحدة من السلايدز إنه هرمون النمو ما بيفرز على طول، بيفرز في شكل نبضات. أعلى نبضة بتكون بعد ساعة ونص من النوم، وفي الأبحاث لقوا إنها اكثر نبضه قويه في افراز الهرمون مو بتجي بعد يعني في حوالي الساعه 10 ل 11 مساء. فلو حسبنا دي المفروض الطفل يكون نام حوالي الساعه 8:30 او 9. دي ما بتحصل
الحين صحيح مع الزمن هذا ما صارت تحصل.
ما يناموا،
طيب
ايوه ما
دكتورة، هنا
يناموا
في
بدري.
سؤال في سؤال للأخ عبد العزيز من ناحية
مهم.
التأثير، وش أهم، الوراثة ولا الغذاء أو النوم؟
هو شوف هم ثلاثة مهمين بنفس القدر، لكن إذا أصلا الوراثة أساسية، يعني إذا الأب والأم قصار القامة يبقى الفرصة ضئيلة جدا ما لم إنه الأب والأم يكون عندهم مرض أو مشكلة. لكن لو هم قصار القامة وطبيعيين فيبقى معناته الطفل حيطلع قصير، أصلا دي ما فيها اثنين ثلاثة. لكن الغذاء والنوم طبعا من الأشياء المهمة، يعني ما في اثنين ثلاثة. لكن الوراثة بتشكل جزء كبير، ودي واحدة من الحاجات الأساسية اللي بنواجهها، لأنه الأهل بيصروا إنه نحن ما نبغى الطفل يكون قصير زي ما نحن قامتنا قصيرة، وما في شيء يتعمل. يعني الفاميليا شورت ستيتشر ما في لها لحد الآن شيء عشان يعالجها، unless إنه البيرنتس نفسهم كانت عندهم مشكلة يعني.
طيب دكتورة، العلاج بشكل مبكر هل حيفيد
مم.
في يعني في مرحلة الطفولة إذا تم أخذ العلاج وأخذ هرمون النمو؟ هل يعني يعني يتم الاستجابة ويصير يزيد قامة الطفل؟
نعم، إذا كان الطفل يحتاج لهرمون النمو، عنده واحدة من الحالات اللي بتستجيب للعلاج بهرمون النمو، بدء العلاج قبل 7 سنوات بينتهي الطفل في وضع طبيعي جدا. كل ما بدأنا العلاج بدري كل ما كانت النتيجة أفضل. كل ما تأخرنا كل ما قلل الزيادة في الطول، لأنه إحنا عارفين إن إحنا كل ما نتأخر بتبقى المشكلة بتاعت إنه ال ال زي ما بقولوا الكلوجر اوف ذا اوسيفيكيا سنترز، يعني بتقفل العظام حقته زي ما بقولوا.
طيب دكتورة، في سؤال الأخت نوف، الطول بأي عمر يتوقف؟
الطول بيتوقف عادة لما تقفل اللي هي المراكز بتاعت بنقول عليها ايه، بنقول عليها سوفيكيشن سنترز، اللي هي الحتات اللي احنا وريناها في العظام. يعني لما يقفل انا حقيقة بالعربي ما قادرة اجيب الترجمة، لكن لما تقفل العظام حقته الاماكن اللي بينمو منها العظم بيقفل، اللي هو حوالي 14 سنة. في بعض الاطفال زي ما احنا قلنا بيتاخروا، يعني بيدخلوا البلوغ متاخرين، فبالتالي بتكون عظامهم لسه مفتوحه، يعني بتاخد معاهم لحد 16 18 سنه. لكن في كل الاحوال يعني من 14 لحد 20 سنه بعدها خلاص. مم.
يعني مثل ما ذكروا إنه، طيب بالنسبة للكبار هل في أشياء تحفز الطول يعني بعد عمر 20 سنة؟
لا الحقيقه كعلاجات لا. في محاولات للجراحه كانت للتطويل، لكن افتكر المشكله في الاعراض الجانبيه حقتها والمضاعفات. يعني بيشتغلوا على جراحه العظام، لكن كادويه لا. بعد 20 بعد 21 ما في طول. إذا سكرت المراكز بتاعت الطول في العظام خلاص. مم.
هو في الغالب
أيوه
الأدوية الحين يا دكتورة هو هرمون النمو هو اللي يزيد
أي
الطول. أي.
أيوه هو
فإذا
الهرمون
أبي
النمو تفضلي.
تفضلي.
آه. أنا بس
يعني
كنت عايزة
هو
أعلق على
هرمون.
حتة إنه الترويج حق الأدوية صراحة لا. يعني بالنسبة للبالغين ما في أدوية بتزيد الطول. زي ما قلنا هم اشتغلوا على الجراحة في بعض الحالات البحثية، والجراحة مشكلتها إنه العواقب حقتها أو زي ما بيقولوا المضاعفات حقتها كثيرة. لكن الأدوية في الأطفال كل شيء عنده علاج. يعني لو مشكلة في الغدة الدرقية بندي هرمون الغدة الدرقية، لو المشكلة في الغدة الكظرية بندي هرمونات الغدة الكظرية، لو المشكلة مثلا في السكري مثلا الإنسولين بندي الإنسولين للطفل، هرمون النمو بنعوض هرمون النمو، لو المشكلة مرض مزمن بنعالج المرض المزمن. فبالتالي الطفل بيطول لأنه أساسا هو عنده مراكز الطول في العظام فاتحة ما سكرت. بمجرد ما إنه مراكز الطول في العظام تسكرت خلاص ما في حاجة بتزيد الطول ثاني.
تمام، واضح جدا دكتور، يعطيك العافية ومشكورة على جهودك. إن شاء الله هذه بداية الخير بإذن الله، وحيتم إن شاء الله التعاون بيننا، وحيكون بيننا إن شاء الله لقاءات أكثر بإذن الله في مواضيع طبية، وما شاء الله من خلال تخصصك الدقيق. هذا شرف لنا، ويعني ما شاء الله أنت قيمة في العلم والخلق. الله يعطيك ألف عافية دكتورة، جزاك الله خير. جزاك الله خير، والله يمسيكي بالرضا والعافية إن شاء الله. طاب مساءكم جميعا. الرجاء تسجيل الاسم والكود عشان الشهادات بإذن الله. يعطيكم العافية جميعا. شكرا دكتورة، ليلة سعيدة.
شكرا لك. بارك الله فيكم. شكرا جميعا. شكرا.